So I'm going to speak more about some specific North Carolina research. And I wanted to start from, again, situating it from my perspective as a primary care pediatrician who has been in North Carolina for 15 years. And so I started as a primary care pediatrician, and I'm also trained as a child psychiatrist, and I was doing about 5 or 6 half days a week in primary care. And I will be totally honest, again, as a specialist and someone who also is doing primary care, I had no idea about the innovations waiver. I had no idea about home and community-based service waivers in general, and I really missed the boat. And again, as someone with extra training, and I feel like I've felt very guilty that for 5 years I really did not know at all about the systems of care for my patients with autism, intellectual disability, or other conditions. And I think Karen Lukin, who many of you know is an amazing disability advocate, I don't exactly know how I got connected with Karen, but she connected me with the council's work previously on the home health initiative, and how important it is to really have medical homes that not just focus on the physical health, but also on the helping young people and adults and children with IDD thrive. And from that, I learned about the innovations waiver. And one of the first things that helped me situate things was looking at my own clinic. And so we have a clinic that has over 30,000 children and young adults who are in the Durham Triangle area at Duke Children's Primary Care, pediatric primary care. And we basically ran a query to see how many of them had an intellectual developmental disability using kind of data from the UHR, and we identified almost 500 patients. And I had this amazing social worker who was working with us named Amanda Zaspy, and Amanda went through and reviewed almost 500 charts, and to basically pull out information related to these individuals. And I'm not going to go through all the information, but out of these almost 500, there were 345 who had an autism diagnosis. There were 48 with Down syndrome, 91 with an intellectual disability that were documented in the medical chart. And again, I'm going to come back to they were documented in the medical chart. This is where disparity may begin, in that sometimes someone who may have Down syndrome and an intellectual disability, only one of those diagnoses is actually visible in the chart. And so we have a real problem with kind of invisibility. There were also a lot of comorbid mental health conditions that were documented. We then looked at and did a lot of other things, but one of the key things we looked at was how, who is their MCO. And, we're in Durham, so the majority of our patients have Alliance. There were some with Cardinal prior to, this is 5 or 6 years ago. About less than half were getting any behavioral health services. And again, only 17% were getting any behavioral therapy, which again is, when you have individuals with IDD, having that low of a number getting behavioral health supports is quite low, and lower than what we would really want. But this is what struck me the most, was that out of this population of 500, 49 or 10% had received a waiver slot, and 11% were on the registry. But almost 70% had never been screened or even evaluated. And that difference between the number, 500, and that are potentially eligible, and only 100 who are either on the wait list or getting the service, was quite disturbing. And I felt very acutely my role as a pediatrician, where I had been seeing patients for 5 years who likely would qualify for the innovations waiver, and I had missed those 5 years of getting them on the wait list. And that, I think since then, the last decade, since I kind of learned about the innovations waiver, it has become a real focus of what I am studying, but also advocating around, that we need to identify individuals with IDD, children, young adults, and connect them to needed services, with innovations being kind of a marker. And our success with getting folks identified and on the registry, I think, is related to whether they get services in general, not just innovation waiver services. So again, this I find is a very striking finding. I'm going to talk about some of what we've done to follow up on that finding in a little bit more quickly. Something else we looked at, and we started looking at education data, thinking about, okay, here's a county, how many kids in that county have been classified as having intellectual disability, which is ID, or having autism. We could look at, okay, again, this is in, probably 5 or 6 years ago, how many children in the county, let's say in 2017, were classified as having an intellectual disability or autism, and how many were on the waiting list. That just gives you a rough count. So in Orange County, there were 93 children in school who were identified as having intellectual disability and coded that way. There were 319 with autism, so that's about 400. Well, the total number of children on the waiting list was 88. And so there are 400 children in school identified, but less than 88 on the waiting list. And again, that seems like consistently, that's just a huge difference. And maybe not all of those patients, all those children would qualify, but it is a much larger gap than we would expect. And similarly, if you look at Vance County, about 275 children with intellectual disability or autism, and only 15 were on the waiting list. And this both points out the challenges related to a more rural county connecting children to the wait list, but also it points out the other disparity that we notice, a difference, that depending on where you live, whether you're coded as having intellectual disability or autism or another school classification is very different. And so in Orange County, many more children were coded as having autism, and in Vance County, many more children were coded as having intellectual disability. Why this is, what this is, I can't fully explain, but there's not a biological reason why there'd be such a difference, in the classification. So we've dug into this in more detail. And again, this is looking again at by race. When you look at, there are approximately 1.5 million children in North Carolina in school, again in 2017. And of those who were white, 10,000 were identified as having autism, and those who had intellectual disability were about 5,000. So twice as many white children with autism as a classification versus intellectual disability. When you move over and look at non-Hispanic Black children, it was flipped. There are about twice as many children who are classified as having intellectual disability as opposed to autism. Again, no biological reason for this. Something is happening in our system that is leading to this difference in classification. Does that difference in classification then lead to healthcare outcomes differences? That's one of those things that when you go from a difference to something being more of a disparity. This just gives you a map, and counties that are redder are counties that there was more autism versus intellectual disability, and counties that are bluer, it's vice versa. There's more intellectual disability coded in schools and more, as opposed to autism. And what you could see is that in the counties where there were more white students, there was lower diagnosis or coding of intellectual disability, and the opposite held true for Black students. That was not true for autism, but autism was related to income. And so in schools in counties that have higher income, more students were coded as having autism. So to summarize what we saw and what our, looking at the educational data, there are a lot of things that come up related to this. It's not that schools are doing the wrong thing necessarily, but there's something happening where there's misclassification, again, we don't know which direction that goes in. And how does that misclassification in schools then translate into access to things like the innovation waiver? How does that misclassification in the medical record similarly lead to, or not being even identified in the medical record, lead to patients' children not getting identified by the systems and therefore not getting the services they need? Essentially, what we did was we looked at Medicaid data and we said, okay, how many individuals have an intellectual disability, autism, or another type of developmental disability in the Medicaid population over a given year? And there were about 53,000. Out of those 53,000, approximately 12,000 had a waiver slot. So there are the 12,000 had a waiver slot, and there are 40,000 who didn't. Again, not all those individuals with intellectual disability or autism would qualify for the waiver, but many would if we had more waiver slots. One key finding was that there were 75% of the individuals who had the waiver were adults over 21. And for me, as a pediatrician, that's a disparity. If you're a child, you're less likely to get this service, even though it is one that could make a huge difference in your life. So there are racial disparities, there are disparities related to income, there's disparities related to geography, and this is an example of a disparity where by age, you're less likely to get something because you're younger. And that, again, is something to keep in mind. When we look by race, if you look at the non-Hispanic white line, there are 27,000 non-Hispanic white patients identified, and 6,700 had the innovations waiver. So that's roughly, 25%. If you go to the Hispanic white category, and this is, again, these are categories that are in Medicaid data, you have 3,000 identified, but only 232 who had the waiver received, which is, less than 10%. So that difference between 25% if you're white versus 10% if you are Hispanic is a major difference, and I would argue is a disparity. One thing that we found in this study is that having the waiver was protective of going into the emergency room. And so that if you were someone who received the waiver, your risk of going to the emergency room was actually markedly less, 27% versus 37%. So 10% less ER visits just by being classified as someone who's had the waiver. When you look at the risk, meaning what's the risk of getting, the risk is the risk of actually having the waiver. So it's a positive if you have a higher number. Again, if you look at by age, 0 to 17 versus over 21, means that children as opposed to adults have a 61% lower risk of getting this service, or 61% lower opportunity to get this service. If you compare Hispanic white to non-Hispanic white, that 0.63 number, that means that Hispanics patients have a 37% lower likelihood of getting the innovation waiver. And if you look at non-Hispanic Black versus non-Hispanic white, it's 0.85, which again is a 15% lower risk. So these are quantifiable numbers to say the innovations waiver is distributed across our state in a way that is different by race. That it, to me, rises the level of a health disparity when you look at things like ER utilization. If you have this service, that is one thing that you can point to and say that is lower, and your health is worse because you don't have access to that service. So both by race as well as by age, there are clear disparities. There's a slight rural versus urban, but it's not actually very pronounced, at least in this data. And that's probably because the way the slots are distributed is that they're distributed by county in a way that really is meant to minimize the rural versus urban.